shoulder instability. Okay, Dr. Lim, you ready?
Okay. Yeah.
Okay, let's start.
So I don't have much of a history, but it's 38 years old with anterior instability. So patient presented with examination anterior apprehension positive with posterior jerk negative.
So every time you looking for the patient that have instability, don't forget to check every direction. Okay. So the apprehension, we should start from 45. Okay. Always check the motion first. 45, 90, and 120. If the apprehension positive at 45, thinking about two things. What is that? Dr. Lim.
The rotator interval.
We call mid-range instability. You're thinking about bone loss, especially the glenoid. Okay, so the positive apprehension will be start very early at 45. Another one is the MDI. Okay, the patient with MDI, when you go higher, the apprehension may be negative. Yeah, it will be positive at mid-range. Okay, so thinking about the mid-range instability, and don't forget to check the posterior also, because some patients also have the combined anterior and posterior. Okay, especially the MDI, they may have positive both anterior and posterior. Okay, so that the jerk test is a posterior inferior. Okay, jerk test always negative in the young, but in elderly patient maybe you may have the cuff tear also. Okay, so this is a young guy, so most of them have no rotator cuff problem. Okay, biceps. Always check the biceps. AC joint.
So AC joint. So we are starting creating anterior superior portal.
So what should be the location of this portal?
It's just above the coracoid process.
This one you need to put it very high. So Putra, you switch off your microphone first. It's like an echo. Okay. So you put it just underneath the AC joint.
Oh yes, just beside the AC joint.
And should be very vertical. Okay. Why?
Okay.
You know why?
Because we need to look at the glenoid and towards the 6 o'clock position.
So this portal have to be very high. Number one, this one you will be away from the second portal. Yeah, especially the very small patients. Okay. So put it underneath the AC joint, make it very vertical. And this one, if you make it very vertical, you can do some other procedures, like sometimes you need to do cuff repair also. You need to do AC joint resection. You can use this portal for everything, for AC resection, for anchor placement, right? And also for the Bancha repair. So thinking about what is your operation. Sometimes you need to do many operation in one setting, in one patient, right? So this combined portal can do many things. Okay. And also it will be far away from the second portal. This is a very common pitfall, because if you put the portal too close, you cannot work. You have portal jam. Okay. Dr. Lim, you switch off your, yeah, because it's echo. Okay, it's better. Yeah. So this portal have to be very high. But if you have the slab lesion, you will change this portal, okay, to the anterolateral corner. We call the transcup portal. Okay. So for the instability, I think portal placement is very important. Okay. Okay, next. Okay, so this one you can go front and back the bicep. So when you come in, you should be just above the bicep. Okay, can you see that? This is just above the bicep, and you can move front and back. Okay, because if you want to do limb massage, your portal will be behind the bicep. When you want to do labral repair, you will be in front of the bicep. Okay, because if you are in front of the bicep, you be difficulty to see the heel sac lesion. Okay, so this portal you can switch in front or behind the bicep. Okay, so that is the anterosuperior portal. Okay, Dr. Lim, next. You can open your microphone.
So we are next going to create another portal, the anterior inferior portal, which will be our working portal or for the suture management. So this portal should
So where should be this portal?
So this portal.
Where should be this portal? Dr. Lim.
Sorry. So the the location should be at the apex of the triangle of the rotator interval. So as high as possible.
Okay, you look at this. You see my cursor, right?
Yes.
Yes. So this is HGHL, you see? This is HGHL. This is subscap. Okay. So this one should be very close to the HGHL. Okay. And sometimes you can see the MGHL. So this one should be between SGHL and the MGHL. And it should be very lateral. You should not put it here. If you put it somewhere here, you have difficulties to put the anchor. Okay, so it should be very lateral. So when you put the anchor in, the trajectory should be perfect. Okay, it should be away from the glenoid as much as you can, but you should not get into the SGHL because you may damage the bicep pulley. Okay, so just next to this SGHL. Okay, so that is the portal. Understand? Should be very precise, and most of the time if you use the supine position, you can see the bubble. You can see the bubble because this is the highest point. Okay, you can see the bubble here. So at the bubble position, yeah, it's our anteroinferior portal. Okay, good. You see that here? I try to put it very lateral, and you see the trajectory. Yeah, it's position is fine. Okay.
Okay.
And then you switch your camera to the anterosuperior. So that is the posterior, right?
Yes.
Yeah, posterior portal. Where is this posterior portal?
Is 2 centimeter inferior to the edge of the acromion, posterior edge of the acromion.
Is it the lutein posterior portal or not?
No, it's not. It's I think it's Kim portal.
It's more lateral.
More lateral, yeah,
Yeah,
correct.
more lateral. So the good thing is that this portal you can see better. You can do the limb massage using this portal. Because if you put it here, you'll be too close to the glenoid, right? You cannot see very well. And also you cannot work from this portal. Because this portal also need to be away from the labrum. You can put the anchor in. You can do the limb massage, okay, using this portal. So for instability, I think this portal very useful. Okay, so it's actually is at the corner, posterolateral corner. Okay.
But for rotator, Dr. Bancha, do you use this portal as well?
No, I use it for instability only.
Okay.
Yeah. Yes. Okay, and put one cannula in. Okay, you see that it's exactly on the heel sac lesion. Okay, so the heel
Correct.
sac lesion, you can use this posterolateral portal for working. Yeah, and I prefer to do the heel sac first. Yeah, we just uh, decorticate, make a raw surface on the heel sac, put the anchor in, pass the suture, but don't tie it. Okay. Someone do it later, but I don't agree because when you come back later, it's not easy because the joint is already tight and that's a lot of swelling. Yeah. So it's not easy to do the limb massage later. And sometimes you need to do some manipulation. Your labor repair will be loose. Okay. So if you do it the last, okay, you just tie the knot. That's it. Okay. That will be easy. And you have the no need to, because if you do it later, the problem is swelling. When this soft tissue swelling, you cannot work. Okay. So now how to do the heel sac. Okay.
So it's debride with the shaver.
Yeah.
Then subsequently, we will perform a microfracture.
Yeah. If you have the ring culate, should be fine, or culate. Okay? Because sometimes this area the bone is very hard. Okay. So I make a multiple holes for bleeding, and that may improve the healing. Yeah.
Then we'll insert the triple loaded suture ankle into
So
the
where
heel
should
sac.
be the location of this triple loaded? You know?
Actually, I'm not so sure.
Not so sure. Putra?
Is it at the wall, not at the apex of the lesion, but on the side, on the wall, on the two sides, if you're using two?
Yeah. So if it's big, I put two. Okay. You can put it not in the center, but we try to put on the edge, close to the cartilage. Okay. Because when you tie the soft tissue in, you cannot see the defect. Okay. You know? Yeah. Put it on the edge. Okay. And this is not too big. I put one anchor using the triple load. But is it big? We put two anchors. Okay. And I prefer to use the why not, because you don't need to tap, you just put it in. Okay. And tension. Someone use the bird beak, but I prefer using the smaller one, the spectrum. Okay. Why we don't use bird beak? Why, you know?
Because the bird beak is bigger in caliber, so
Yeah,
will
it's
cause
big.
more soft tissue damage.
Right. It's bird beak size is always big, and the problem is when you put in and you try to catch the suture, you manipulate. Sometimes your hole is getting bigger. You make more soft tissue damage. Actually, the capsule, because this area sometimes capsule is very thin. You make a big hole in the capsule, and when you tie it, sometimes you cut through. Okay, so try to make it very less invasive. Otherwise, your hole will be bigger. Okay,
Okay.
and then retrieve this. So the first one, we retrieve only one. Okay, 1, 2, 2, 1. You understand, Lawrence? Why
Yes, sir.
1, 2, 2, 1? Why?
1, 2, 2.
The first one only 1. The second one is 2 suture in one hole. Okay. Another one is also 2. 1, 2, 2, 1 is totally 6, right?
Yes, sir.
Yeah. You understand?
Yes, I have an idea, sir.
Okay, I show you.
Is it so that the one can be used to tie down the center?
Right. 1, this one. And the second one is 2, right? 2 in one hole. And then 2. And then 1. Okay. So that will be 4 holes. Okay, in the capsule. But totally 6 suture.
Yes, sir.
Right? That is 1, 2, 2, 1. Got it?
Yes, sir. I got it. So you can close it side by side
Right.
for each.
Is it similar to when we tie the side-to-side repair between supraspinatus and subscap? So we put 1 in the subscap and 2 in the infraspinatus to do a side-to-side. Is it similar?
This is mattress. This is a mattress. You try to put the soft tissue into the defect. What's your question? Putra again?
No, I just asked, is it similar to when we repair the rotator cuff? We use one suture in the side in infraspinatus, and then we put another suture in supra, so we tie them together like a side to side.
Right,
is it
right,
similar
right.
for this?
Right, same things, same things. Like apex reduction, right? Right, same
Apex,
things.
yeah, like apex reduction.
Right. Okay.
Yes, sir.
How to this is the sorry, how to okay. Okay. You see the screen now?
Yes.
Okay. So after the multiple holes, then we put the suture anchors, the triple load. Okay.
Bancha, if you use 2 anchor, you use triple loaded as well, is it?
We double is enough.
Double. Okay.
Triple too many sutures. Okay. And the another point is that you should not go too far. I mean from the insertion. Okay. I mean this stage should not cross to labrum. Understand? You should not go too far. You see the defect. Okay. Look at the defect. Okay. Here the defect, right? The distance from here to here should be the same. Okay. So you put this soft tissue into the defect. Okay. If you come too far, you come close to the labrum, that means you go to medial. Okay. You catch the muscles. You're not catching the tendon. You want to catch the capsule and the tendon, not the muscles. Okay, that will make the shoulder stiff after the surgery. Okay, like that. So we throw the spectrum. We always use the smaller one. Okay, and then this is the first one, right? We put 1 first, and then 2 to 1. Okay, and then retrieve it back like that. Okay, one by one. Okay, the second one. Okay, like that. Okay, this is 2, you see? 2.
To suture.
2 suture. Yeah, then put back. Okay, the third one here. And also we will close the hole, the posterior portal after surgery. So I will put it between, okay? Like that. Okay. And the fourth one, this one. So you see that if you tie the knot, the posterior portal will be closed also. Okay. So now we get all right. And then you put the switching stick in again and put the suture outside the cannula. Okay. And now we come back to the label detachment. So use the bank cut knife to release and lift up, okay, to until 6 o'clock. So if the patient has the very loose joint, maybe you can go down beyond 6 o'clock. Okay, if the patient have the sulcus side positive, in that situation, I will reduce the capsular pouch also. The lens, your microphone, okay, and then
Okay.
you can denude the cartilage here. You can do two ways. You can use the RF or you can use the QLED. Yeah, but you need the very sharp QLED or ring QLED. Okay, because if it's not sharp, sometimes you can damage or it can slip into the good cartilage. Okay, so this is another way you can use the RF to make a trough. So why you should make a trough here? Gong. Why you need to make a trough here? You see, I make a trough using the RF. Why?
To create the bone for the ankle
And
on the glenoid surface.
you want the soft tissue to heal on the sphenoid surface, right? So that you
Yes.
make a small trough. But someone make a really big trough like some Japanese doctor or Korean doctor. The trough is too much. So we make very little trough like 2-3 millimeters. Okay. And after you use the RF, you need to use the QLED again, right? To make it fresh. Because you need the good bone for the healing. Okay. Like this. Make it from 6 to 3 o'clock, right? You see, and then you use the rough.
Right.
This step also very important. You need to detach the subscap. No, the labrum until you see that here. Sorry, here like this. Okay, you need to see like this and feel like it's totally released. You need to see the whole subscap and can feel that this soft tissue is freely movable. Okay, don't start to repair before doing this because you cannot shift the tissue up. Okay, and then use the RAS and QLED to make a good raw surface. Oh, sorry. Okay, shaving to 6 o'clock. That is 6 o'clock. Okay. But this step, you should increase the pump pressure because it will be bleed. There will be bleeding on this step, right? Maybe we increase up to 60. Yeah, it will bleed for a few minutes and then you can decrease the pump to 40 again. Okay. And use adrenaline. You see that? I use the RF, okay, to create a trough. But after you create a trough, you should kill it, okay, to remove the dead bone also. You see, kill it and rest to create a good breathing surface. Make sure that the soft tissue is freely movable. Okay, and you see my first stitch is always coming from the back. Why? Bang. Why the first stitch need to come from the back?
Because we need a post to out of the joint, to I mean the stitch out of the joint, out of the glenohumeral joint.
No, because you want the big bite to eliminate the axillary pouch. If you come from the front, you cannot make a big bite at 6 o'clock. Okay, Bang?
Okay, thank you ครับ
If you come from the back, you can make a big bite, okay, from the back to eliminate the axillary pouch. Because most of the cases, they will not just have the anteroinstability. This is anteroinferior instability. So you need to eliminate the pouch, okay, like that.
This is also the capsular shift, right?
Right. This is the capsular shift, okay. Especially the patient that have the MDI. MDI is not enough. You need to do more. Maybe next time we're talking about the MDI, okay? We do more. I do the pancapsulolaboplasty, okay? I shift is more than this, okay? But this is the anteroinferior. So we shift the axillary pouch, make a big bite, and you use two hands. One hand is to lift the labrum up, okay? And then you can make a good bite. If you didn't release the capsule or labrum completely, it will be difficult for you to find the tip of your needle. You know why, Putra? Why?
Because the needle will be behind the glenoid.
Yeah, right. If you did not release it completely, you cannot find your needle because there's still some soft tissue block your wheel. Okay, the needle cannot get up. Okay, try to do it completely, and then you can easily find your needles. Especially if you're dealing with the bony Bankart, it's more difficult. Okay, in the bony Bankart, you need to do very complete release. Okay, because it's more difficult to find the tip of the needle. Okay, maybe next time we're talking about the bony Bankart. Okay. Okay, next, Dr. Lim.
Okay, after the first pass, we'll insert the first ankle at the 5 o'clock position. So this is the why not?
It's not why not. This is the suture fix from the Smith-Nephews. It's
okay.
see?
Okay.
It's double.
Suture fix.
Why not is also good, but the problem is that the hole is very small. Yeah, and when you put the anchor in, sometimes it can slip for the first one. Okay, and also the suture of the why not is too bulky. That's why I like this one. Okay, because it's in the joint. So the number one is strong enough. This is ultra braid. Okay, and careful, someone put the anchor from the back. In the past, I also do that. I put the anchor from the back, and if you use the one from the back, one from the front, what's the problem, you know? The first anchor, you can also put it from the back. It will be better position. It will be here. It will be like 6 o'clock. But this is not 6. This is like 5:30. Why? We don't put it upon the back.
If you put it lower down, then you don't get the capsular shift.
Yeah, number one.
Also,
if you put too low, you cannot get the capsular shift because you want to shift the capsule from bottom to the top, right? So the anchor should be higher than the labrum. You cast the labrum lower than the anchor, so you can shift it upward. Okay. And what is the second reason?
Maybe the anchors will be in different directions, so the labrum will be not uniform. The repair may not be uniform. The question is if you put it from two directions,
one from
right?
the back, one from the front, what would
Then
happen?
I think the reduction won't be concentric. It will be like in two different directions.
Actually, the major reason is that these two anchors will merge. Okay, and you can break the first anchor when you drill. Your suture can be ruptured also. That happened to me. Okay, so I stopped doing that. So if you put the anchor from the front, okay, and another from the back, these two anchor is too close? What would happen? You see, it's go this way, right? What would happen? It's merge. Okay, so when you drill into the bone, so you take it out, the first anchor, the rupture, the suture was broken. Okay, careful, especially if these two anchor is very close. Okay,
So your direction should be divergent, like
with
a
diversion, right? But all the second anchor, it should be here. You know, let's say you have MDI, your anchor is here, another one should be here, not here, because you see the direction, right? It's merging. Okay, so if you want to do that way, I will go a little bit further, not too close. Okay, then we get these two, and then the second stage would be from the front. Okay, make a big bite. So you prefer the simple or mattress? Soy.
Yes, sir.
You prefer simple or mattress for the first stage?
For me, sir, I will do simple for the first stitch because I need it to be stronger.
So someone recommend the mattress for the first stitch. They put the single load, okay, and made mattress. So you need to do 2 bite, right, for the mattress.
Yes, sir.
But I used to do that, but now I stopped doing that. Yeah, I found no difference. And the mattress sometimes you cannot get a good bite, a good bump of the tissue because you push it down like this. Okay, you're not getting a good bump of the tissue. Okay, but this still controversy. Yeah, someone do like Mason Allen's. They do one mattress, another one is simple, so it's like Mason Allen's, right? Like we do the rotator cuff. Yeah. Okay. But I try not to make too many bites to the labrum because you can cut through the tissue, right? So before you tie, you see that we need to pull up. Okay, you tie the knot, always tension, because if you didn't tension it up, all the tissue will be stuck at the 5-6 o'clock, and you have no tissue for repair on the top. And this way you can share the tension, share the load to the second anchor. Okay, you got it? See that? You use the suture retriever. Okay, pull the labrum up when you tie the knot. Okay, so you share the tension to the second anchor also. Okay, like that. Always do that way until the last one. Like that. You see? You tension, share the load to the upper one. Okay. Okay, that's the first stage. Second one, try to make a big bite. Sometimes the patient may have the capsular tear also. You need to make a very big bite. Don't worry, you never make it too big because you limit by the curve of your suture hook. Okay, make the biggest bite. Don't worry, because the label repair is just not just the label repair. It is a capsular label repair. because capsule is always loose, right? You need to do the capsular label repair. Okay? And tie the knot. Like that. Yeah, I use the simple also, yeah. Cut it one by one. I prefer using the double load for every anchors. The direction of the your drill is also important. Okay, try to make it very perpendicular to the surface, otherwise it can slip on the cartilage. Okay, and don't move. You need to see the anchor before you drill. Why, man? You need to open the anchor before you drill. Why, man? Posawat? Why?
การถามว่าทำไมต้องเห็น
The anchor should be in hand first. It should be well prepared before you drill. You know why?
not sure ครับอาจารย์
Because you have very short time. You need to stay very stable when you drill the hole, right? The anchor should be suddenly put into your handle, because you can easily slip if you put it too long, because you need to hold it very firm. นะรูมันจะหาย the hole will be disappear. You cannot find the hole, or you can miss the hole. Okay, if you don't prepare your anchor. Okay, this is important because the hole very small. If you just miss it 1 millimeter, or you change the direction, okay, you lost your anchor. That is the very common mistake or pitfall during the label repair. Okay, and you will feel very sad because it's very costly, each anchor. You miss the direction, right? Especially the 5 o'clock, because at 5 o'clock you need to pivot also, because the direction, right? This is glenoid. This is glenoid. When you put it like this, right? You come from the top. Okay, you can easily miss it. So the way I do that is that I will push it like this, and I try to pivot to make it very perpendicular, you know. So it's not easy to hold it for too long. You be fatigued and you miss the direction. Understand? Especially to 5 o'clock, because you come from this, right? Anteroinferior, and I need to pivot like this. Okay, to otherwise your anchor will miss the hole. Okay, understand? Everyone understand, right?
Yes, sir.
Okay, so I think the most important one is the first anchor. Okay, the rest is not the problem. Okay, after that, see, so now you have 6. Okay, and every anchor share the tension. So after that, you tie the suture. Before tying the limb massage, you should slide first. And remember the sequence. You tie from bottom to the top. Okay, the first one is a tiger blue, right? You tie the tiger blue first. Okay, and then the black, and then the blue one. Okay, because you can see all the time. Okay, like that. Okay, and finally you cannot see the huge sac anymore. Okay, so you need to know, you need to train how to, because this is blind. Okay, the last step, yeah, it's blind, because you need to tie the knot by closing your eyes. Okay, make sure that the knot is on the capsule, it's not in the soft tissue. Okay, so that is the label repair with the limb massage. Any questions?
Bancha, I not quite understand when you're saying that you are closing the posterior portal.
Okay.
by repairing the remplissage.
Okay. So here, so this is the hole, right? We have 4 holes, right? And between that, there's the hole here. This is our posterior portal.
Okay.
So when you tie the knot, you see? When you tie the knot, the hole also closed. Understand?
I see. Understand.
Because it's between. Okay? So when you tie the remplissage, your hole is already closed. Okay? So I can close the posterior. But actually, it's not so necessary because patient have no posterior instability. But actually, if the patient have posterior instability, this is important. You need to repair the labrum. At the same time, you need to repair the capsule also. Okay, otherwise it will be the weak point. Okay.
Okay.
Putra,
Dr.
any
Bancha,
question?
when you are tying the remplissage, the position of the rotation will be in neutral, or do you do it in a bit of external rotation?
No, I put it neutral. I think the position is the same because you're always in the traction. I think if you repair the remplissage in this position, if you're not going too much medial, if you not go too medial, there's no problem. Okay, so for my patient's outcome, you look at the OPD, right? Even the patient have done remplissage, there's no difference with the patient have done remplissage without remplissage. The range of motion is no difference. Yeah, I think not the problem.
Sir, when you
Thank you,
tie
Dr.
the
Bancha.
knot, you tie it
Lawrence?
from the posterior. If I remember, you tie it from the posterior portal, right?
Yeah,
The
right.
cannula posterior.
Yes.
So I get
Again.
you tie the knot from the posterior portal, right?
Yeah.
All 3. Yeah. Okay.
Mm-hmm. So
And
we
then
tie the knot. Yeah, we take the cannula out. We take the cannula out and slide the suture in. Yeah. Tie it that way. Okay. From inferior to superior. Okay. Any more questions? Come, Bank, Man, Soy.
None, sir. Thank you.
Actually, if you want to, if we are worried about doing it blind, is it okay to do a lateral viewing portal like a rotator cuff and look at the infraspinatus from the back while tying?
So we did that in the past. I did subacromial arthroscopy, okay, and tie the knot. It takes some time. I think there's no difference. Okay. So you can do another way is you put the camera into the subacromial space, try to clean the basal tissues, and then tie the knot. Okay. But there's no difference. No difference. And most people now they did this way. Yeah, they tie the knot blind. Okay. But make sure that your knot is on the capsule. You can feel, okay, when you tie the knot. I prefer using the sliding knot because using the sliding knot, you can be sure when you tie, you pull, right? The suture will be on the capsule. You can feel that it stopped on the capsule, okay? And then you can tie the knot. Actually, it's not on the capsule. It's on the rotator cuff. It's on the infraspinatus, okay?
So you're tying outside the capsule, right? So can you see it from the
outside the
subacromial
capsule.
space? You cannot see it from the subacromial space, right, sir?
I can see from subacromial space.
The
You can see
outside
that we tying the knot over the infraspinatus.
Or the infraspinatus will attach to the lesion, but the knot will not be seen, right?
Yeah, you can see the knot. Sorry,
You can
because
see the knot. Okay.
you're repairing the capsule and the tendon together. So the limb result is not just the capsule, it's the tendon together with the capsule filling into the defect. Because,
Right. Thank you.
okay, because just the capsule can be easily torn. Yeah, it's not stable enough. It can be cut through also. Yeah.
Thank you, sir.
Yeah. Bank.
Compare the bony Bancha. Which trick do you need more do in bony Bancha?
So the bony Bancha, you need the 5 o'clock portal because it's not easy to hook around the piece of bone, you know. So the way to do that is you need to come from very inferior like this. Let's say this is 6 o'clock, okay? This is 5 o'clock. So the way to do that, you use the straight one coming from underneath, okay? And go around the piece of bone, okay? And then you need the metal. The suture hook should be special. It's not the nylon or PDS because it will be blocked by the piece of bone. Sometimes you have piece of bone that block the tip. So better way to use the metal is available in Johnson company, Mytech, Johnson. Yeah, we call shear. So for the bony Bancha, I prefer to use that one because um, inside the cannula, inside the needle, is not the PDS, it's a metal. So you can push this metal through the tip of the needle, okay, using the 5 o'clock portal. Yeah. Maybe next time we're talking about the bony Bancha. Okay.
Thank you.
Yeah. So you need 3 portal in the front. You need antero-superior, you need the antero-inferior, and another one is a 5 o'clock portal. And it's proof that this 5 o'clock portal is safe to the axillary nerve. Okay. The IMHOF report about that is safe, no worry. Okay. Gong and Posawat, any question?
No, sir.
No? Man. Man ไม่มีนะ Man no question แมนอยู่ไหน so windy where are you now man it's so windy
อินดี้ผมเปิดพัดลมเลย
oh you on the beach right okay so we move to the next